Hello and welcome to the modeling background tutorial for the COVID-19 simulator developed as part of the EUVABECO project. This presentation will show you the mathematical model that works in the background of the simulator. Understanding this model will help you interpret the simulator's results. The simulator allows you to explore what-if scenarios. For example, what would have happened if vaccinations had started earlier, or if a new virus variant had appeared at a different time? During the COVID-19 pandemic, a major concern was predicting how many infections and hospital patients to expect in the coming days or weeks. Mathematical modeling is a powerful tool to answer such questions. Therefore, during the pandemic, we developed a model for Germany and its federal states. It describes infections, hospital and ICU patients, ventilated patients, and fatalities. Within the EUVABECO project, the aim was to adapt this model for other European countries, including Greece, Luxembourg, and Poland, and to integrate the adapted models into simulation tools for counterfactual analyses. Over the course of an infection, patients pass through several stages of disease. First, they become infected and can infect others. Second, they experience sickness of varying severity. Third, they either recover or die. The transitions between these stages depend on various factors, such as the patient's age, the virus variant, or protection through vaccination or non-pharmaceutical interventions like lockdowns. Understanding these factors is key to building a good model. To build a mathematical model, observed data is needed. For Greece, data was extracted from a GitHub repository that collected COVID-19 pandemic data from various sources. This included daily infections, hospitalizations, ICU admissions, fatalities, and testing numbers. Additional data on age-stratified vaccinations and variant spread was obtained from the European Center for Disease Prevention and Control. Finally, data characterizing the hospital stays of 2,081 COVID-19 patients in Crete was available. This data was collected between August 2020 and December 2023. Where Greece-specific data was not available, for example, age-specific hospitalization risks, the model was informed by data from Germany. There, we had built the original model using a more comprehensive database. The first part of the model follows a standard epidemiologic model for infectious diseases. It separates the population into three groups from top to bottom. First, the susceptible population, people who are not immune and can get infected. Second, the infectious population, people who are infected with COVID-19 and not yet in quarantine. They can still infect others from the susceptible population. And third, the population with a confirmed infection. These individuals are in quarantine and cannot infect others. They are also assumed to be immune, so they cannot be reinfected. Each of these three states is described by one mathematical equation. The number of susceptible people that one infectious person infects on average is called the reproductive number RT. If RT is above 1, each infected person infects more than one other person on average, and the epidemic grows. If RT is below 1, the epidemic shrinks. This number changes over time, for example through lockdowns, behavioral changes, or new virus variants. That is why it is written as RT, with T standing for time. On the right side, you can now see the model results. The top row shows the input data, the spread of virus variants over time, and the vaccination trajectories in Greece. Below on the left is the model estimated reproductive number RT. You can see how it fluctuates over time, reflecting changes in restrictions and population behavior. Two major RT peaks stand out, one with the emergence of variant Delta and one with variant Omicron BA.1. On the bottom right is the weekly incidence per 100,000 inhabitants. The dots represent observed values from Greece, while the line represents the model prediction. As you can see, the model captures the observed infection dynamics well. The model was then extended to differentiate between patients treated at home, hospital inpatients, and those requiring intensive care. Several factors influenced who ended up in which category. These are shown in green. Vaccinations protected patients from severe disease. Older age and male sex were strong risk factors for hospitalization, and different virus variants were associated with different disease severities. For the subgroup of inpatients requiring ICU treatment, age and virus variant were the strongest predictors. In the plots, you can see the numbers of infections, inpatients, and ICU patients. The observed numbers are shown as points and the model predictions as lines. Notably, in 2022, daily case numbers peaked while ICU patient numbers remained lower than in 2021. This was largely due to the Omicron variant causing less severe disease. Finally, patients from both ambulatory treatment and hospital care could either recover or die from COVID. These clinical outcomes again depended on several factors. The risk of death was higher for patients requiring inpatient or ICU treatment, and for older and male patients. The risk also varied across virus variants. Vaccinations provided protection against fatal outcomes. Additionally, recovered patients were not necessarily protected forever. The model allows for reinfections, specifically for individuals who recovered from wild-type, Alpha or Delta, and were later exposed to the Omicron variant. This structure now represents the full model. For each of the colored compartments, observed data was available against which the model was fitted. In total, 24 differential equations are needed to describe the flow of patients through all these stages. Here, you can see how the disease stages of COVID-19 were translated into the model stages you just learned about. These, in turn, were translated into systems of mathematical equations. Each box and each arrow from the previous slides corresponds to one or more equations that describe how patients flow between stages. You don't need to understand these equations to use the simulator, but this gives you an idea of the mathematical foundation working in the background. Here we see the overall results of the developed model. All observed data from Greece is shown as dots and model predictions as lines. On the left, you see the cumulative numbers. On the right, the weekly numbers. From top to bottom, infections, inpatients, ICU patients, and fatalities. The key takeaway from this overview is that the model describes the pandemic trajectory in Greece well across all 4 indicators and over the entire pandemic period. Since our model was originally developed for Germany, it is instructive to compare the pandemic settings in both countries. This comparison also helps us understand some of the modeling choices we made for Greece. Because Greece and Germany differ vastly in population size, all indicators are shown per 100,000 inhabitants to allow for a meaningful comparison. We can see that variants of concern and vaccination trajectories were similar, with Greece reaching approximately 5% lower vaccination coverage. Test numbers were substantially higher in Greece, resulting in a lower positive fraction despite similar case numbers. This difference in testing numbers arises from the fact that Germany only counted PCR tests in their statistics, while Greece also included antigen tests. This explains the vast increase in Greek test numbers in summer 2021. In comparison to Germany, the reproductive number showed large peaks during the emergence of the Delta and Omicron variants. This slide shows the number of cases, hospitalizations, ICU admissions, and fatalities. Both countries had similar trajectories of case numbers. However, since 2021, Greece saw more ICU patients and substantially more fatalities. Now, I want to show you an example of the counterfactual simulations I mentioned at the beginning. The simulator allows us to explore what-if questions by changing specific parameters and observing how the pandemic trajectory would have changed. For this example, we look at the beginning of 2021, when the emergence of variant Alpha and the rollout of vaccinations happened in parallel. The questions we want to answer are, what would have happened if Alpha had appeared just 1 week earlier, and could a different vaccination strategy have counterbalanced this earlier appearance? Both of these questions can be answered by performing variant modifications and vaccination scenarios in the simulator. For this, we simulate the period between January 1, 2021 and September 1, 2021, and successively perform a variant emergence shift for Alpha to 1 week earlier, change vaccination coverage to 99%, and perform a vaccination campaign shift to 2 weeks earlier. The results show that if variant Alpha had appeared 1 week earlier, the peak incidence in April 2021 would have increased from 3,000 to 4,300 cases per day. Could vaccinations have counterbalanced this? Increasing vaccinations by 43%, shown in violet, would have reduced the peak to 3,400. Combining the increase in vaccinations with a 2 weeks earlier start, shown in yellow, would have brought the peak down to 3,200. So while vaccinations helped, neither scenario could fully offset the impact of the earlier variant appearance. A similar trend can be seen in the hospitalization numbers. Importantly, though, the increased vaccinations show a substantial long-term effect, as you can see in the later part of the curves. However, this trend of case numbers approaching zero is an important example of where the model reaches its limits. In reality, as case numbers drop, restrictions would have been loosened and people's behavior would have changed, leading to new increases. The model, however, assumes that the underlying dynamics remain the same regardless of the altered scenario. This is why long-term predictions from counterfactual simulations should be interpreted with caution, which brings us to the model limitations I will discuss next. Still, the model has several limitations caused by assumptions we had to make due to lack of information. First, the model assumes lasting immunity following infection. The sole exception is Omicron reinfections among individuals previously recovered from wild-type Alpha or Delta. Second, while the model adjusts hospitalization rates for testing intensity, no undetected infections were explicitly included. This means that immunity following an undetected infection is not accounted for. However, these two limitations have opposite effects. One overestimates susceptibility, the other underestimates it, so they may partly counterbalance each other. Third, vaccinations were only stratified by the first full vaccination and the first booster. Later, booster vaccinations were not accounted for. These limitations all cause uncertainty regarding the population's susceptibility to further infections. Therefore, model predictions far into the future must be interpreted with caution. As we just saw in the simulation example, short-term effects were captured well, but long-term projections are less certain. To summarize, the mathematical model that powers the Greece COVID-19 simulator describes the pandemic trajectories well across infections, hospitalizations, ICU admissions, and fatalities. We identified and implemented various factors influencing virus spread and disease severity, including vaccination rollout, variant characteristics, and patient age. Some of these factors can be altered within the simulator to explore counterfactual scenarios, as we just saw with the Alpha variant example. When interpreting simulation results, keep in mind the model limitations we discussed, especially for long-term projections.